This is an overview of an article entitled Outcomes of Contemporary Family Screening in Hypertrophic Cardiomyopathy, published in the April 2018 issue of Circulation, Genomic and Precision Medicine. Hypertrophic cardiomyopathy, or HCM, is among the most common inherited cardiovascular diseases, and a common reason for referral for cardiovascular genetics evaluation. HCM is caused by pathogenic mutations in cardiac sarcomere proteins, most commonly involving the genes encoding the beta-myosin heavy chain and cardiac myosin binding protein C. Individuals with the disease have hypertrophied, or thickened, myocardial ventricular walls. This can cause symptoms of heart failure, including exercise intolerance and shortness of breath. Pathologically, these genetic alterations lead to structural changes in the myocardium called myocardial disarray, describing the loss of normal parallel myocyte alignment and increased fibrotic substrate. Clinically, this increases the risk of ventricular arrhythmias, which can cause syncope or loss of consciousness, and even sudden cardiac death. Inheritance of HCM is typically autosomal dominant, implying that somatic inheritance of the abnormal gene has a dominant effect over the normal gene copy, creating risk of disease. Hence, one needs only one abnormal copy of the gene to have the disease. Thus, children with a parent who has HCM have a 50% chance of inheriting an abnormal copy of the gene. Importantly, however, that does not mean that they have a 50% chance of manifesting the disease. In general, because of phenomena such as variable expressivity and incomplete penetrance, not every individual with an abnormal copy of a given gene will express the phenotype or clinical expression of the genetic variant. For this reason, there's been discussion among experts as to how to use genetic testing in the management of HCM patients and families. Traditionally, recommendations for screening family members of affected individuals, called probands, have been centered around serial clinical screening evaluations, following patients clinically, as well as with echocardiograms and electrocardiograms. However, whether genetic testing can provide more efficient triage of the need for genetic testing in related family members remains uncertain. In the Netherlands, where the authors of the paper under discussion work, genetic testing for family members of HCM patients is covered by health insurance programs as a screening tool for family screening. This strategy requires the identification of a pathogenic mutation in the proband, which is generally fulfilled in up to 60% of cases. Genotype-positive relatives and relatives without genetic testing are advised to undergo repeated cardiac evaluation. Genotype-negative relatives are recommended to be discharged from the need for further follow-up. It remains unknown, however, whether this is an effective strategy. Specifically, the overall yield of genetic testing in such families is uncertain, and, more importantly, how strongly the genetic findings correlate with the potential to manifest disease. The authors thus sought to examine the results of genetic testing in a population of patients referred for HCM screening, and the subsequent correlation with clinical disease manifestation. The authors examined data from 777 relatives of 209 unrelated probands with HCM who visited the cardiogenetic outpatient clinic of the Erasmus Medical Center for screening purposes between 1985 and 2016. The flowchart on this slide shows the results of genetic testing in probands and relatives. Genetic testing was performed in 94% of probands, of whom 76% were genotype positive, 17% had a variant with uncertain significance, and 7% were genotype negative. Genetic testing was not performed in 6% of probands due to premature death in 7 and refusal by 6 of them. In the 47 probands without an identified pathogenic mutation, about 24% of the probands, at least 8 sarcomeric genes were tested, and next-generation sequencing was performed in 72%. In 12% of probands without an identified pathogenic mutation, there was no family history of HCM. Genetic testing was performed in 80% of relatives. 43% were genotype positive, and 57% were genotype negative. The pie chart on the left presents the implicated genes in genotype-positive probands. Complex genotypes were present in 5% of probands and included homozygous, digenic, and compound heterozygous mutations. Of note, during follow-up, 3 pathogenic mutations were reclassified as variants of uncertain significance based on updated analyses. The pie chart on the right shows the results for the genotype-positive relatives, showing similar proportions. Next, the authors looked at the proportion of genotype-positive relatives and the proportion of relatives diagnosed with HCM at first screening, shown here across different age groups. As you can see, there was an incomplete correlation between genotype and clinical phenotype. Characteristics of relatives diagnosed with HCM versus those without HCM are summarized in this table. Relatives diagnosed with HCM were more likely to be genotype positive, were older at the time of screening, 44 versus 34 years, were more likely to be male, were more frequently symptomatic, were related to probands with a younger age at diagnosis, and were differently related to the proband. Multivariable analysis demonstrated that genotype status, with an adjusted odds ratio of 4.23, which was significant, as well as male sex, proband age at diagnosis, and age at the time of screening were independent predictors of HCM diagnosis. More details can be found in the published article on the journal website. The authors then looked at the survival of patients depending on the presence or absence of HCM. Survival patterns of genotype-positive relatives, genotype-negative relatives, and relatives without genetic testing were similar. However, as you can see, the overall survival for all groups was actually quite good. Overall, the key findings of this study on HCM family screening are: 1. At first cardiac screening, HCM was diagnosed in 37% of genotype-positive relatives and 17% of relatives without genetic testing. 2. Genotype-positive status, male sex, age at time of screening, and proband age at diagnosis were independent predictors of HCM diagnosis. 3. 16% of relatives without abnormalities at baseline developed HCM during 7 years of follow-up. And 4. Survival rates in genotype-negative relatives, genotype-positive relatives, and relatives without genetic testing were all good. In sum, this article provides important insights into the use of clinical genetic testing as part of screening for Mendelian cardiovascular disorders and, hopefully, the early basis of an increasingly better understanding of the care of these patients and their families.